A very good afternoon to everybody. I'm Dr. Amrita Chawla from the Division of Conservative Dentistry and Endodontics from the Center of Dental Education and Research, and I'm here to present the second CCR for today. So we know that dental pain is one of the most acute pains which we have in the maxillofacial region. And interestingly, dental fear is the fourth most common feared apart from heights, snake bites, and acrophobia. Sorry, acrophobia, heights, and physical injuries. So when we're coming to odontogenic pain, it is pulpal in origin and periodontal, or it can be trauma-induced. Coming to pulpal pain, it is basically straightforward. We do the diagnosis based on subjective and objective findings, and the patient may have sharp shooting pain or may experience spontaneous pain. The patient may also have pain which is exaggerated with thermal stimuli. Specifically for irreversible pulpitis, nocturnal pain is the hallmark, where there is increase in the pulpal perfusion because of the increase in the venous return while the patient is lying down. The treatment is straightforward. It is endodontic therapy, and it's a treatment which is performed across the globe, and United States performs about 20 million root canals per year, and interestingly India is double the number, about 40 million root canals per year. The success rate, it enjoys a high success rate to I would say about 99%. uh, we do have failures. In spite of the best root canals we perform, we do have endodontic failures to about 12%. It can be attributed to reintroduction of persistent microorganisms in the interradicular region, extraradicular infection, or maybe due to any foreign body reaction, or simply it may be a true cyst. So these cases are treated by retreatment. First, we try non-surgically, and then we do, if not healed, then we do surgical. And it again has a success rate to near 90%. But in spite of our best efforts by doing primary endodontics and retreatment, these patients do come back to us with persistent pain, and the percentage is about 5.3. And in these cases, 3.4% we attributed to non-odontogenic pain. I would request Dr. Vijay to give us a clear understanding further, please.
Thank you, ma'am. So, before coming to a case score, we must know what is the history and clinical examination. So, let's discuss. So, a 37-year-old female, she reported to the Division of Conservative Dentistry and Endodontics, CDR AIIMS, New Delhi, with a chief complaint of pain in left lower back teeth region from past 3 years. However, the patient was apparently well 3 years ago when she first experienced pain in her left mandibular premolar teeth region. The pain was spontaneous on the onset. It was localized, unilateral, constant, dull aching with bouts of intermittent throbbing episodes. The pain was aggravated on brushing and chewing. However, there was no sensitivity on taking hot and cold fluids. So the patient visited the patient was native of Rajasthan, so she visited a local dentist in January 2019. The dentist made a diagnosis of pain of endodontic origin. So he advised root canal treatment. So he performed root canal treatment in left mandibular first and second premolars and placed the crowns. However, the pain was aggravated and it was not relieved. So after 15 days, the patient again visited the same dentist. So the dentist again performed the retreatment on 2 teeth. The pain was apparently relieved a little bit, but not completely relieved. So in the meantime, the patient moved to New Delhi, where she visited another dentist in May 2020. The dentist there made a diagnosis of failed root canal, and he performed selective retreatment only in one tooth, first premolar, and he replaced the crown. But the patient was not relieved, and she again visited another dentist in January 2021. So the dentist again performed selective root canal in first premolar. However, the dentist removed both the crowns and advised patient not to get the crowns replaced until she is relieved of her pain. However, the pain persisted and in August 2021, patient visited the Division of Conservative Dentistry and Endodontics with her chief complaint. So there was no history of awakening at night due to pain. There was no worsening of pain when patient was lying down or there was any change in posture. There were no associated symptoms such as swelling of gums, pus discharge, change in taste, burning or itching sensations. There were also no symptoms of dry mouth and dry eyes. There was no history of watery eyes, running nose, stuffy nose, tinnitus, headache, nausea, and vomiting. Also, there were no triggering factors associated with pain, such as light, sound, or any stimuli. And there was no pain or sensitivity changes in any other parts of the body. Also, there was no history of trauma or any surgical intervention in that region. When the patient reported to the dental center, at the time of reporting, she was in severe pain and the VAS score was 8. However, when asked, the average pain during past 4 weeks was just 5, and the maximum pain she experienced in past 4 weeks was very severe to the scale of 9. This represents the average change in the pain level during a typical day, where when the patient gets up in the morning, she was apparently fine, and the pain gradually increases from mild to moderate, and it persisted to the moderate level, but suddenly it increased to the severe category, and it persisted as a severe for some time, few hours, and then it comes back to the moderate category, and it still persisted as a moderate till the time patient slept. The patient gave no history of diabetes mellitus, hypertension, asthma, bleeding disorders, thyroid disorders, or any cerebrovascular accident or migraine. Patient was present at the time of reporting, was not taking any medication except for SOS painkillers, and there was no drug allergy was reported by the patient. Patient was a homemaker. She was on mixed diet with normal appetite and bladder and bowel movements. She had habit of grinding teeth at night. So, but there were no other deleterious habits. She maintains good oral hygiene and brushes teeth daily with toothbrush and toothpaste. And there was no familial disease in her family. On general examination, patient was conscious, cooperative, and perfectly oriented in time, space, and person. The patient was well built and had a normal gait. The patient was afebrile at the time of reporting. Her respiratory rate, blood pressure, pulse, all were within normal limit, and there were no signs of pallor, icterus, cyanosis, clubbing, or edema. We can see on general external examination there was no gross facial asymmetry seen, and the patient had competent lips, a convex profile, and there were no swelling or sinus, external sinus were present. When lymph nodes were examined, the submandibular, submental, and cervical lymph nodes all were normal, and no lymphadenopathy was noticed. So, going to the internal examination, the mucosa appeared to be normal. The gingiva was normal in color, size, and consistency. Although there were mild calculus and stains were present, the oral hygiene was stated to be good. There were no intraoral soft tissue or hard tissue swelling was present. There was no intraoral draining sinus tract was present. Periodontal status was good. There was no periodontitis. There was pocket depth within normal limits of 3 mm. However, what we noticed on periodontal probing was patient had mechanical allodynia, like when probing was performed on the affected side in the gingival sulcus, she felt pain. However, on the contralateral side, no such sensation was present. So we gave local anesthesia, local infiltration in that on the affected side. We give local infiltration, and then again perform the periodontal probing. But still, this painful sensation persisted. Hard tissue examination, the patient had all 28 set of teeth were present. Although 2 teeth we can see had previous restorations and crown preparations done, what we find was there was tenderness in the vestibule region, both buccal and lingual side on palpation. But surprisingly, the teeth were non-tender to percussion, both on horizontal and vertical percussion. And the tooth mobility was, sorry, sir? So this is the tooth number, sir. Tooth number. Uh, sir, this is third quadrant and tooth number 4. So we divide the oral cavity into 4 quadrants: first, second, third, fourth. So this is the third quadrant, means left mandibular left quadrant, and this is the fourth and 50th. Yes. We suspected that there could be a crack, so we examined the tooth under magnification, but we could not find any crack. So we used trans illumination, but however the light was evenly distributed, so we could not find any crack or fracture in the tooth. So we've taken the X-ray. On radiograph, the root canal filling appears to be satisfactory, and there was no periapical pathology or periodical pathology, and the periodontal bone level was also satisfactory. So this is a 2D picture. So whenever we have any doubt, it is better to go for 3D. So we plan and advise a Cbct scan to the for the patient. And on the Cbct scan, we saw that all the mandibular and maxillary third molars, which were missing, like patient had 28 set of teeth, so those were impacted, and the root canal filling appears to be satisfactory on the Cbct scans also. We can see this is the tooth number 3, 4, like left mandibular first premolar, in which we can see the on the all 3 sections there was no periapical pathology was seen here. And also with relation to tooth number 3, 5, that is left second mandibular premolar, the root canal filling was satisfactory and there was no periapical pathology, no signs of any bone erosion was seen. So based on these findings, we could not discern any odontogenic cause. So we shift our diagnosis to some non-odontogenic cause as a toothache, and in the differential diagnosis we kept myofascial orofacial pain, TMJ pain, post-traumatic trigeminal neuropathy, craniocervical disorders, and persistent idiopathic dentoalveolar pain as differential diagnosis. So to find out what the cause of her pain, first we examine the muscles of mastication. On examination of temporalis muscle, anterior, middle, and posterior fibers, and anterior and the tendon of temporalis, and on examination of masseter muscles, there was no tender spots were there. Also, when the patient was asked to protrude and open her mouth against the resistance, and also asked to make lateral exclusive movements against the resistance, so there was no tenderness observed. So on these basis, we rule out the myofascial orofacial pain, because that time the patient generally have some trigger points which can cause the pain. So our next differential diagnosis was TMJ pain. So we examine the TMJ. The mouth opening was within normal limits, around 40 mm, and when the patient was asked to do TMJ movement like opening, closing, and lateral movements, so there was no deviation in the mouth opening, and there was no tenderness on palpation of the TMJ region. So since we could not identify any tenderness in the TMJ region, so we also exclude TMJ pain as a cause of her pain. We examine the branches of trigeminal nerve, like ophthalmic and maxillary and mandibular, and also we see the corneal reflex. But on examination, the patient could not identify any difference in both the sides. And when we try to see the somatosensory changes, we touch both the contralateral side and the affected side with a cotton, with a cold spatula and with a pricking with the periodontal probe. However, the patient was failed to see any difference in both the sides. So on these basis, we rule out any type of somatosensory changes in this patient. So to rule out any craniofacial disorder, because cervical spondylitis often cause pain, and patient come to us with the sometimes the patient comes and say they are having pain in their jaws. So we ask the patient to on the flexion or extension movement there was no pain. So we did not see any reason to refer her for any spondylitis problem. So on these basis, on the basis of exclusion, we made the diagnosis of persistent idiopathic dentoalveolar pain. Hence, this was our diagnosis of exclusion, and it is not something new. Since old ages, in John Hunter in 1778 said there is one disease of jaws which seems in reality to have no connection to the teeth, but for which the teeth are generally suspected to be the cause. Now I ask my colleague Dr. Siddharth to discuss.
Thank you, sir. Now, the major challenge in the diagnosis of this condition is basically because of the confusion in taxonomy, the diagnostic criteria, and the multiple terminal. There has been a major confusion in the taxonomy, diagnostic criteria, and the different terminologies which has been used to define this condition. It has been called as initially as idiopathic periodontalgia, then it has been called as phantom tooth pain, similar to that of a phantom limb pain. However, the most common terminology which has been used is an atypical odontologia, and it has been accepted by the International Association for Study of Pain and International Headache Society. However, with the development of this international classification of orofacial pain in 2020, the term persistent idiopathic dentoalveolar pain has been accepted. Now, this terminology is advantageous because it is coined by a consensus panel following ontological principles. The same international classification for orofacial pain has defined this condition as persistent intraoral dentoalveolar pain, primarily unilateral with variable features but occurring daily for more than 2 hours per day for more than 3 months in the absence of any preceding causative events. As far as the epidemiology is concerned, the prevalence of Pdap is difficult to estimate due to the challenges in diagnosis, but it has been reported to be as high as 2.1%. This study was based on a university setting, so it cannot be generalized for the general population. Hence, most of the study has focused on finding the incidence of Pdap, and that is around 0.3 to 1.6% following endodontic therapy. Now, considering 30-40 billion root canal treatments are performed in India, even this percentage includes substantial number of patients. As far as the gender is found, it is mostly seen in female patients in middle age group between 30 to 60. And important is it has been seen that the onset is associated with a traumatic event like a root canal treatment or extraction or any other surgery. However, spontaneous onset of the pain is also not uncommon. It is seen in around 35 to 40% of the cases. As far as the diagnostic delay is concerned, the average diagnostic delay, it has been seen in a study, in few studies actually, the diagnostic delay between the onset of the pain and the accurate diagnosis is around 2 years, 22 months. And the number of healthcare consultants, the number of healthcare professionals which have been consulted were 7. It ranged from general dental practitioners to endodontists to oral surgeons to neurologists to orofacial pain specialists and so on. And most important, around 75% of them underwent unnecessary dental interventions. The pathophysiology, it is still enigmatic and it's a diagnosis of exclusion as discussed by my colleague. Initially, the diagnosis that it was because of a neurovascular disorder or because of a sympathetically maintained pain is now abandoned. Psychological origin has also been attributed to this, but it has been seen that such patients are associated with comorbidities like anxiety, depression, so it is not possible to know whether they existed before or they developed as a consequence of it. Moreover, studies have established that there is no specific psychological profile of such patients. So most of the evidence is now for neuropathic pain. It has both peripheral and sensory components because if the condition is associated with a history of trauma, I mean a root canal or extraction, then because of the injury of the nerve, the release of local inflammatory chemical mediators, and it leads to the increased afferent signaling and peripheral sensitization. Not only peripheral sensitization, because of the release of the nerve growth factor, it contributes to the sprouting of the nociceptive fibers to sympathetic fibers. It leads the nociceptive fibers to fire when sympathetic fibers are triggered, and it leads to the sensitization of the second order and third order neurons, also called as central sensitization, leading to mechanical allodynia, hyperalgesia. This sprouting of the nerve fiber is not only seen in the peripheral fibers, it is also seen in the central nerve fibers. So all this nerve injury theory is valid when we think of the onset of the pain following a traumatic event. When the onset is spontaneous, then this theory still doesn't hold true. Then some phenotypic and genotypic factors may hold some role, as it has been seen. It shows a female predilection. Genetic and phenotypic factors are also there. When the pain is spontaneous, it is seen mostly the pain starts as a toothache localized in a tooth, and it is often seen the patient then visits the dentist, and invariably he undergoes some endodontic treatment or extraction. In those cases, two scenarios emerge. First is the original pain, it is not arrested by the dental procedure and its quality did not change. Second, a new kind of pain started after the procedure, clearly distinguishing it from the original pain. The possible signs of Pdap is it is mostly localized to dentalveolar site. It is described as pulling, dragging pain. Most important, the pain does not disturb patient sleep, as seen in our case also. We can differentiate it from an odontogenic pain which awaken the patient from sleep. Second, there is no obvious source of local pathology, and repeated treatment fails to resolve pain. As we can see in our case, the patient underwent root canal treatment 3 times. The diagnostics, so how to diagnose such case, there are diagnostic criteria given by ISOP. The first is it has to be intraoral dentalveolar pain localized to intraoral dentalveolar site, tooth or alveolar bone. It is recurring daily for more than 2 hours for more than 3 months. The pain is of deep, dull, pressure-like quality, and clinical and radiological examinations are normal and local causes have been excluded. The management is again challenging because of any lack of treatment protocol and lack of any gold standard medicines. The first is to reassure the patient, okay, the pain is real, it's not imaginary. Second is to educate the patient that no dental intervention is required now. Second, the treatment protocol is same as that of any neuropathic pain. Tricyclic antidepressant are the first line of drugs. It has to be started with 10 mg per day for a week, followed by 20 mg per day, maximum 75 mg per day. And our patient was also treated similarly. She was reassessed for pain reduction, and the pain started to reduce after 2 weeks, and 60% of pain reduction was observed by 5 to 6 weeks. The mechanism of action is this tricyclic antidepressants are non-selective serotonin and non-noradrenergic reuptake inhibitors. They result in increased activity of descending inhibitory pain pathways. Now, again, not all the patients respond similarly to this TCA. Alternative drugs are SNRIs like duloxetine, anticonvulsants like gabapentin, pregabalin. The evidence is limited as far as Pdap is concerned. Lidocaine injections, the localized treatment is also indicated, since all these anticonvulsants, antidepressants have side effects, drowsiness, dry eyes, etc. Lidocaine injections were also tried, but however, they have a very short therapeutic window. They relieve pain only for 120 minutes. Botulinum toxin injections are a promising tool. There is no randomized control trials so far. Only few case studies. The maximum case studies have 9 patients only. But yes, they have shown to reduce the pain, and that can last as long as 6 months. And this is the future area of research. Topical application of medication has also been used, like eutectic mixture of lidocaine cream, capsaicin treatment. Their mean reduction of pain was seen in 50%, but again the evidence is limited. No RCTs. Psychosocial therapies like cognitive behavioral therapy have also been tried. Advantage is non-invasive nature of the intervention. So the take-home message is, first, to know such a condition exists, and to understand that the pain is real. It is not imaginary. We cannot ward it off as a psychological pain. Second, it is a diagnosis of exclusion. The old saying that when you hear hoofbeats, think of it as a horses, not zebras. It doesn't hold true here. Okay, we have to exclude all the odontogenic pain. We have to exclude all the common non-odontogenic pain like MPDS or TMJ pain. Third, it is important to sensitize our colleagues. Okay, no endodontic or no oral surgical treatment in such patients. To conclude, last but not the least, this condition actually is now idiopathic. What does idiopathic means? It means we don't know the cause as yet, as for today. So future collaborative interdisciplinary research is required so that we can omit this idiopathic thing and we can benefit self and benefit patients. Thank you.
Thank you very much. I think we are on time, and We would appreciate your feedback rather than anything on this, because as we always say that it would be a learning experience for us also if in case somebody else has come across such cases, please. Yes, sir, please. Thank you.
Thank you very much for that very interesting presentation. Also, thank you for getting so many people to attend this CCR. We benefited from the large number of CDR people here. We feel good to have a CDR with you. Happy to be doing ours with you. Next time, we'll try and contribute also to the number of people in the audience. You know, these idiopathic pain syndromes, we see them in dermatology too. Oral pain, sometimes genital pain, and pretty much similar in the sense that often they get treated by physicians, because physicians know only one way to treat patients. Just as dentists do procedures, physicians prescribe treatments, surgeons cut things out. But they recognizing that this is a person whose problem requires a different kind of approach is, I think, really important. I think you brought that out very well. I was wondering, was the psychiatrist associated with your management of these patients? Because we find that even though you may think that this is not a psychiatric illness, if you have them help you with managing the stress, the anxiety, and the depression that often goes along with these pain syndromes, outcomes are better than when we manage them alone. I wonder what you did.
Yes, we agree to your point of view, sir. But what difficulty we have is that, as Siddharth said, that we're not very sure whether the patient had a predisposing depressive condition or a psychiatric condition, and that's why the patient is having such symptoms, or the prolonged pain which the patient has been experiencing has gone. Your point that we refer them to psychiatry, that's their last stop anyway. Most of these chronic patients with pain end up there. So I'm sure that they would be referring them there, and ultimately your point that they would get benefited if we add the psychiatric component, yes, maybe.
Yeah, that's the point I want to make. Because one intervention that I sometimes see is that the psychiatry referral is a way of getting that patient out of your clinic, which is not a very good way to do it, because patients also don't accept that kind of a referral. So what we usually tell them is that we need, both of us need to manage your pain. That the dental management and the psychiatric management have to be done together in order to get the best responses. Just as we say skin as well as dental as well as psychiatric. And you might find that
definitely
the outcomes are better if you're doing both than just one.
Thank you, sir. Thank you very much. Thank you. Yes, Sujay.
I was struck by that nice graph that was made on the pattern of pain, where there's absolutely no pain at night, and then there's a gradual increase, then it plateaus off, and then there is a spike, and then there's a gradual decrescendo. So in your, did you find this similar pattern of exacerbation of pain and relief of pain in this particular disorder? Because this itself may be a pattern strong enough to make a diagnosis of this entity.
Yes, exactly, sir. It has been seen in the review. When the patient wakes up in the morning, at least for 30-40 minutes, there are no pain, and the pain starts increasing. And always there is a persistent baseline pain with acute exacerbations. The pain scale is around 4 to 5. But when it again, exactly, it has been reported.
Is this very specific for this Pdap, or do you see that in
honestly,
odontogenic
sir,
and
honestly for neuropathic pains also, for other neuropathic pains also, sir. Of like that post-traumatic trigeminal, not specifically for Pdap.
Right. It's not too specific, but it's one of those.
I think we'll call it a day. Thank you very much, please. Thank you.